First, we have a pre-recorded talk by Philip Anderson, who is in the US, so the time difference didn't play well out here. So we have a pre-recorded talk, and Philip Anderson is an assistant professor of emergency medicine at Harvard Medical School, Department of Emergency Medicine, Brigham and Women's Hospital.
Hey everyone, good morning. My name is Philip Anderson, and I'm talking to you here today from Boston. I'm sorry that I wasn't even able to organize a direct video link due to the time differences, and instead had to pre-record this to be able to participate today. You know, when I first heard about this conference and was invited, I was really excited to be able to come and be there in person, because it's been a while since I've been able to visit Region Halland. And then COVID hit, and with all the travel restrictions, I wasn't able to come. And but I do want to say that I think it is remarkable how the organizers have been able to transform this whole event into a really successful virtual webinar. And I think that really is a great demonstration of the kind of ingenuity and creativity and dedication that really lies at the heart of innovation, which is the theme for the conference today. So I really want to congratulate all of the conference organizers, as well as all of you for making this whole event happen. So I want to start just by thanking the conference organizers at Halmstad University for inviting me. It's a real pleasure to be able to talk with you today about the collaboration that we had with Region Halland. My background is in healthcare delivery, where I've worked for nearly 3 decades. As an emergency medicine physician. I'm currently based here in Boston at the Brigham and Women's Hospital in the Department of Emergency Medicine. And I also teach emergency medicine at Harvard Medical School and do research in healthcare systems delivery and healthcare analytics. And in addition to that, I lead our external collaborations group called Global Business Strategies, where we have the opportunity to work with healthcare systems in different parts of the world. And it was really through that work that I came to have the great privilege of being able to work together with many of you and many of your colleagues in Region Halland on this very successful collaboration and journey of innovation. So within a few short years of adopting information-driven care, Region Halland has been able to do something really remarkable. They've been able to both save approximately 10 million euros per year in healthcare resource utilization, and also at the same time to become one of the highest performing healthcare delivery systems in Sweden in terms of patient quality and population health. Now, they were able to do this by innovating and figuring out new ways of using their data in smarter ways to implement new care delivery processes that would allow them to both improve outcomes and lower costs, as well as to expand data transparency across the whole organization. And they were also able to harness the power of artificial intelligence and big data analytics to deliver higher quality care to patients and personalized precision medicine. Now, this is a story about international collaboration and what we can accomplish when academia and healthcare delivery systems work together. It's also a story, though, about the untapped potential for how we can use big data in healthcare to tackle stubborn problems that have really plagued us for decades. So today I want to share with you the story of how we as organizations were able to come together and leverage our respective resources and strengths to develop and implement some really innovative new approaches for how to optimize healthcare delivery systems, as well as using healthcare data to its full potential. So I teach emergency medicine at Harvard Medical School, mainly working with first and second year medical students, teaching them physical exam skills in the emergency department. I don't spend a lot of my time at the medical school. I spend much more of my time here at the hospital, Brigham and Women's Hospital. Brigham is a big institution. It has over 1,000 inpatient beds and admits nearly 60,000 patients annually. There's about 1.7 million outpatient visits, and the staff includes around 3,000 physicians as well as physician trainees, and a total of about 20,000 employees. The Brigham is a part of a larger organization called Mass General Brigham, which is an integrated health system, or we also say accountable care organization, that serves about 1.5 million patients annually in the northeastern part of the United States, New England. Mass General Brigham has a large network of hospitals, both university hospitals as well as community hospitals and specialty-oriented hospitals, as well as outpatient care through the community physician organization, as well as a network of home care services, similar to the kind of care that's delivered by the municipalities in Region Halland. It also has a large network of rehabilitation hospitals. So I want to pivot now to talk a little bit more about the collaboration that we had between Brigham and Region Halland. The collaboration itself formally went from the early part of 2016 to the early part of 2019. But this period was actually preceded by a number of years where we were having a lot of ongoing discussions and dialogue between clinicians and leaders in the two systems. And a lot of that discussion was around some of the common challenges that we faced, and based on that recognition that we really had a lot of common problems that we were all trying to solve, that led to a desire really to work together based on a belief that we could leverage the resources and the strengths that both organizations had, and come up with some new solutions that we believed would be able to allow us to improve care delivery, both in Region Halland, but also here in Boston and in other parts of the world as well. Now, some people have asked, why should Brigham be interested in wanting to work with Region Halland and vice versa? And it turns out that one of the reasons for that is that we actually have a lot in common as organizations. Now, when I was talking with you before about Mass General Brigham and how this is structured as what we would call an accountable care organization or an integrated care delivery system, this is actually a very similar model to how Region Halland is organized, where you have a fixed amount of resources or budget that the organization needs to use in order to deliver all of the care needs for a particular population of patients. And that's true in Region Halland for the entire population. Here in Boston at Mass General Brigham, that's true for part of the population that is covered by Medicare and Medicaid, the federal health insurance program here in the United States. The other thing that I would say that we share is that in both of our systems, we are top performers. As you heard before, Region Halland has been recognized as one of the top performing systems in the entire country. Likewise, Brigham and Mass General have also been recognized as being among the top hospitals in the United States. So when we started the collaboration with Region Halland, one of the initial focuses that we had was to try to figure out new ways and better ways of delivering acute and unscheduled care delivery. But we quickly realized that in order to be able to understand that scope of care delivery, which is really much of what healthcare systems tend to do, we need to be able to get our arms around all of the data for describing all the different types of patient encounters that happened for all of the patients who live in the region. And so when we say all of the encounters, we're talking about all of the inpatient admissions, all of the emergency department visits, all of the outpatient and primary care visits, really everything that happens to patients in the course of receiving health care. And we also realized that if our goal was to try to improve outcomes and to reduce cost, we needed to be able to quantify all of those things. So we had to be able to link data describing outcomes and cost, as well as the things that drive cost, which are the resources for care delivery in the healthcare system. So we had to come up with a data model that would link all of this data on the actual clinical encounters, the outcomes of care, or all the clinical data, the resources such as the inpatient beds or human resources, as well as the actual costs of care. And so we actually had to develop some methodologies for being able to describe and quantify what capacity meant in the system, because we needed to be able to account for the cost of unused capacity, and then also some methodologies for being able to translate the existing financial information into patient encounter level cost data. The resulting system that we came up with has come to be known as SHARP, and I'm not going to spend a lot of time on this because Markus is going to talk about this in a little bit more detail later. But the key things that I do want to just point out is that we chose to use all of this enormous and comprehensive data set to be able to allow us to answer what we thought were really important questions, both at the healthcare system management level, but also at the physician provider level. And these types of questions are ones which we believe are very consequential for being able to both improve the healthcare system and its ability to deliver high quality care at lower cost, as well as being able to deliver more precise and personalized medicine at the patient level. And one of the really exciting things about this is the ability to use this for doing machine learning predictive modeling, where we can model and predict the risk of having healthcare outcomes that are of interest, that we can intervene earlier on to be able to either prevent conditions from happening or to reduce their severity for patients. One of the ways that the region has been able to use this data model to improve the delivery of care generally across the system is by being able to analyze proposed new healthcare processes to understand in advance what their likely impact is going to be on both outcomes and cost for particular patient groups. And then by doing this type of evaluation on a whole bunch of different processes, it then becomes possible to compare them in a value matrix like you see here, so that healthcare system decision makers are able to have a more quantitative input in their decision-making process for what they're going to choose, because you have a limited capacity for being able to implement new initiatives at any given time. And so you want to choose ones that are going to make have the biggest impact. One example of how we are using this data set, or rather how Region Halland is using this data set to be able to improve the care of patients, is by being able to systematically look at how evidence-based guidelines are being implemented at the individual level and at the patient cohort level. So there's hundreds of evidence-based guidelines that are in place through the national health authorities, but we don't really have a good idea of how systematically or well those are being implemented across the population. SHARP allowed us to look at that more closely, and this is an example of one evidence-based guideline for atrial fibrillation and anticoagulation to prevent strokes that was able to be implemented to give feedback to primary care doctors about whether or not their patients are receiving the optimal care, and if there are potentially some patients for whom there's an opportunity to improve their care. And this has the potential to be able to reduce the number of preventable strokes, as well as to have cost savings associated with those reduced number of preventable strokes. The really exciting frontier, I think, for how we can really improve healthcare moving forward is through the use of big data analytics and AI predictive modeling to be able to identify individual patients and patient cohorts who are at an increased risk of developing a particular health care outcome, which could be, a particular disease process or an acute event of some kind, and then to be able to use that information to intervene earlier for those patients so that it can be possible to either prevent that outcome from happening or to reduce the severity of or reduce the progression of that, the natural history of that disease process. By doing this, we can potentially diagnose disease before it happens, which it sounds magical, but it is really, I think, an incredible opportunity for being able to transform how we deliver care, or really a whole different way of thinking about prevention. And so this is one example of a predictive algorithm that has been developed and implemented in Region Halland for being able to predict the risk of having a new onset mental health diagnosis within the coming year in young people. And the take home here, which I think is very exciting, is how accurate these algorithms have been shown to be in their validation process. I just wanted to quickly mention that we have published a number of examples of the predictive models that we have been developing, and there are a number of others that are in development right now, which I think also have great promise in being able to improve care for patients in different categories. So in summary, I think I just want to say that if we think about what our main goal is in healthcare and in trying to develop sustainable improvements in care delivery, what that really looks like and what that means is to try to have the best possible healthcare outcomes for our patients delivered at the lowest cost. And this is really another way of describing value. In order to be able to understand how to do this and then to actually accomplish it, we need to be able to use data to its full potential. And this means that the data that we have available, we need to organize it and we need to link it in ways that support what I would call value-based population health analyses. In other words, being able to describe and quantify the outcomes as well as the cost of at the individual patient encounter level, at the population level. That's really, I think, the key and what's at the heart of what we have done here in together with Region Halland. The other part of this is that it requires a lot of data. And once we have all of that data together, it has to be linked and it has to be curated so that it can be used. But when we've done that, it gives the potential to be able to develop predictive learning algorithms, which is a big part of what we are calling personalized precision medicine. And I think lastly, and perhaps most importantly, I think we have to really emphasize that because we are using patient-level information, we really have to be extremely careful to treat this data with great care and to do our utmost to protect it. We have to do all of the work that we're doing in accordance with with the data protection requirements such as GDPR in order to protect patient privacy. When we do that, we can then maintain the public trust, which is, I think, so important for being able to succeed in this kind of work. So that brings us to the end. Thank you very much for your attention today. I want to again reach out to the conference organizers and thank them for putting on this wonderful event. If you do have any questions, I would be more than happy to respond to those. Please contact me by email. You can see my email address here below. I would love to hear about the work that you're engaged in and look forward to seeing you again soon. Thanks very much. Have a good day. Bye-bye.
Now it's my great pleasure to introduce our next speaker. It's Markus Lingman, and he's an MD and PhD and Chief Strategy Officer at Halland Hospital Group and Senior Consulting Cardiologist. Please, Markus, welcome.
Thank you. Thank you. Okay. Thank you for having me today and the invitation for speaking on the subject for the day, which is seemingly information-driven care. And I will dig a bit deeper into that subject as we go along. So I want to start by actually a Swedish quote, and it's by Anna Nergård, whom you listened to earlier this morning, and it's from her final report. And it says basically that we are today lacking the capabilities of understanding our complete healthcare system. And which means that the ecosystem that James Barlow referred to earlier is driven by a blind driver. The slides are a bit too fast, but at the same time, Jenny Nordborg, who also spoke earlier, wrote a report to the national government in Sweden called the National Life Science report, and it basically also says that if we don't utilize healthcare data, we don't have a life science industry in Sweden. So this is a challenge, but we want to pick up that thrown glove and do our part. And our part is now under the notion of information-driven care. And what is that? It's a notion that I came up with a number of years ago, but after we did all the work that Philip just referred to. And it's basically working along what I usually refer to as the value chain of knowledge. And it's working all the way from the data, which we have abundances of in healthcare and outside healthcare, through information, understanding the data, and also getting insights from it, but that's not enough. You need to transfer insights to actionable happenings and changes and transformations in healthcare so that you actually reach the level of value to the patient. And those last two steps are very, very challenging. But once you make this journey, you not only enable precision medicine or personalized medicine or person-centered healthcare, different notions for similar aspects of the transformation of care, but also going from imprecision management of healthcare and healthcare systems that are super complex into precision fact-based healthcare management. So there's a huge difference. In order to do this, you need the kind of data platform or data infrastructure that Philip just referred to. What we did in Halland is just what he said, that we brought together the different aspects of data in order to bring about insights from all aspects at once. You cannot deliver or understand a patient treatment if it's supposed to be integrated in the caretaking of the patient, if you don't also understand how it affects the staff that works around it and also the costs that are associated with it. And once you have that, which we do have now, you can do a number of things that Philip referred to. Variability analytics in order to understand who does well and who does not so well, in order to find rooms for improvement and new ideas for improvement. But not least, and on your bottom right, you see the opportunity for applied artificial intelligence, which is very much requested now. And society seems, not least within healthcare, to have challenges translating those capabilities into real-world value for patients. So what do we do in order to translate this information and insights into value for patients? Well, you need to do a number of things in parallel. So you need to be able to do advanced analytics using advanced software like Python, R, and others, but you also need simpler methods for describing your insights and your data to the operational staff in healthcare, for them to be able to relate this information to reality. And that means that you need to have the dashboards and the usual ways of presenting information to your coworkers. And you need tools for presenting the same information to the financial department so that they can relate to what we are all talking about. And that's the value chain, bringing more value to patients, but from several perspectives at once. For the financial department, we developed what we call the patient encounter costing methodology, which enables us to understand the complete cost chain across the healthcare system, across its internal borders. To be able to work on all these issues and topics across the healthcare system, we now established what we call Center for Information-Driven Care in the region. And it's a semi-virtual establishment entity where in the core you have the people who actually deal with the data, develop the structure, etc. But as you can see on this slide, around and partially integrated into this department are several skills. There are chief medical officers, the legal team, the R&D team, the HR team dealing with information regarding the staff, but in a common setting, and that's part of the key. So having done all this pre-work or workup, we are now in a situation where we can produce a lot of knowledge together. And here are just a mishmash summary of the projects that are at the end in green, ongoing in yellow, or starting in orange. And they are, for example, understanding patterns of who will not fare well in the healthcare system, the healthcare ecosystem, and who will fare better, in order to direct resources to where it's actually making a change. But I want to pinpoint a couple of more projects, and the latest one that is seemingly important to this ecosystem of projects is the XAI aspect. We need to actually explain or be able to understand how these advanced analytics work, in order to be able to trust them, but also make them compliant with MDR regulations, etc., going forward. So we have a number of projects, and there are more coming up, and these are conducted together with collaborators that I will return to, not least the university where I'm at now. So, having said this, we are in a very good position, relatively speaking, at least in Sweden. We have a good longevity. The people of Halland have very long lives, and the cost of healthcare are very low compared to other regions in Sweden. And if this is related to fact-based management and precision medicine, personalized medicine, well, that's not really easy to say. But there is a temporal association between the development of these methodologies and the quality and efficiency of the healthcare system as a whole. So going forward, what are we doing at the moment? Well, we're focusing even more on collaboration with different stakeholders, because developing these capabilities takes a lot of knowledge, and it takes a lot of engagement, and takes a lot of different kinds of knowledge. Computer science, medicine, legal issues, all kinds of aspects that has to be taken into account, or else you have a showstopper simply. The first collaboration that brought us forward was actually from the AI perspective specifically, and this is a while ago, was the Kaiser collaboration, where we were able to translate capabilities from the vehicle industry and the development of intelligent vehicles into healthcare, which are two areas where you deal with a lot of data, but also a lot of complexity. We reach out to parties outside the region as well, certainly nationally. This is one other example where we work together with Lund University, and our part here is to understand, are we able to follow the trajectories and paths of risk across the lifespan, in order to be able to, using predictive modeling, prevent negative trajectories from happening in the first place. So this is population health oriented, but it's also, as you can see on the slide, embracing adjacent research areas like ethics, legal parts, socio-legal parts, and implementation research. Another important and national collaboration is actually named information-driven care, and it's financed partially by Vinnova and driven by AI Sweden and SKR. And here, together with the university, the Region of Halland is the driver of the first of a number of national initiatives, and as a first under the topic of information-driven care, and the first other healthcare system that wanted to jump on that train was Karolinska University. So they are deeply integrated in the work. And we have, as you can see, a number of other regions that are happy to collaborate going forward. I would also like to mention that within the information-driven care notion, we reach out also to the near care initiatives. And this is one of the examples where we try to increase and leverage the capabilities of people or patients being cared for in their natural environment, most often in their homes, and how that using information of things technology can be integrated in the health ecosystem that is supporting their holistic healthcare situation. Other collaborative initiatives are on the topic of natural language processing and the combination of natural language processing and machine learning, where we try to understand how we can create value out of the abundance of unstructured data that exists in healthcare. Data is sometimes well structured, but also sometimes very messy. But in the mess, the patterns are still there, and the patterns have predictive values. So using natural language processing methodologies for looking for those patterns, and using machine learning in order to translate the patterns into predictions, where you can also even identify and, in this case, predict patient harm before it happens. That's very promising and value creating once we reach that goal. And this is an ongoing project. An important aspect of working with healthcare data is the integrity aspect. So we need to at all times and almost at all costs protect the integrity of the people we serve. And for doing that, we need to dive into another adjacent subject, and that's privacy-preserving technologies, where we can actually use data from different sources without really combining them other than on a meta level. And you can do this from a number of perspectives and in a number of ways, and which way you're supposed to use depends on the question and need at hand. But you need to be able to handle this toolbox in order to scale your solution and keep privacy. So this brings me to the final slide of my presentation, and that's merely an invitation that if you would like to be part of one or several of our collaborations, you can either reach out to me or any person in the team in person, or you can just go to leapforlife.se, and we're happy to discuss any good ideas that might come up on the horizon. Thank you.
Thank you so much, Markus. One question we have received is What implications will the advancement of medical AI decision-making bring to Swedish healthcare?
Oh, that's a lecture in
That's a
itself.
small
That's a small one. Well, basically, I can recommend a book on this topic.
Perfect.
By Eric Topol called Deep Medicine. It covers the field very well, but to boil it down to something very short, it's about patient safety, about handling the complexity of healthcare as an ecosystem, but also as a biological individual that is complex, and freeing up time for the staff that are today dealing with work that is not as value creating as we would like it to be able to spend more time with the person that they are at work for serving. So that's like.
Yeah. Well, you did a great job with that big question, I think.
Thanks. Thanks.
But connecting back to what we heard in the previous section about collaboration, in your view, what stage do you see as the most challenging in terms of managing the innovation process?
So I would like to then return back to my fourth slide, I think, on the value chain of knowledge, where under the umbrella of information-driven care, we want to make the journey all the way from the raw data to actual patient value. Mm-hmm. And the last two steps are the most difficult. And we have work together with teams at this university where we try to understand that step better, because the ideas are there, the solutions are there, but how do you actually integrate it into the real world care for the carers and the patients to really profit from these capabilities. That's the most challenging step, I think.
So bringing the actual end recipients or beneficiaries' experience of value, really proving that.
Yes, in hopefully a measurable way, where the patients say, I feel better now, or I live longer now, because that's where we go to work, why we go to work.
And in section 4 today, we will learn more about the implementation step and what metrics we can use or KPIs to do that. And as a medical specialist, I imagine you have lots of experience in seeing the world as a healthcare provider. But if you imagine yourself when you're 80 years old, and on the other side of the fence, so to speak, the recipient of healthcare, what kind of healthcare systems and services do you hope to be there for you?
The one that I don't even notice. I don't want to be thinking about my health when I'm 80. I want to be out boating and stuff, and things should be going on, supporting my health in the background, and while I play tennis. That's my vision.
The invisible healthcare system.
Hopefully.
Well, that's great. Thank you so much, Markus.